Afternoon, everyone. We are going to go ahead and call to order at noon. The meeting is currently being recorded. Shelley, can we do roll call, please?
Amber Rice. Dan Spate. Franco Castro.
Present.
Frank Walter.
Here.
Gail Bradley.
Present.
Eve Godstinker.
Present.
Jason Johnson.
Here.
Joshua Gaither. Kevin Foster. Stevie Merrill. Present. I count 9. We have quorum.
All right. And I think,
Shelley, this is Dan Spate. I'm here.
Oh,
I just had to get off mute.
sorry. I count 9. We have quorum.
excellent. Thank you very much, everyone. All right, just a reminder, the meeting is being recorded. This recording will be posted to the Bureau's website. So anything said as part of the meeting minutes or recording will be posted to the Bureau's YouTube site. In the packet, there is the attendance report. A reminder, if you missed 2 or more consecutive meetings, Bureau staff will reach out to you to see if you are interested in continuing on the committee. As you can see on the roster, virtually everyone's term except for one has expired. However, you do get to continue in the committee per the bylaws. So thank you for those of you that have submitted their applications. Sorry, there's a little bit of an echo. I'm going to try to figure out where that's coming from to mute that. There we go. Hopefully you fix that. But we will continue with the committee members as such. We thank you for your participation. We have 1 vacancy, a physician who specializes in severe acute head injury treatment or spinal cord care, demonstrated interest or expertise in emergency medical services. Right. And moving on next to, if anyone is interested in those roles, you can go ahead and apply to the Governor's Board and Commission website. And we will move next to the Bureau report. The Bureau report is in the meeting packet. So for those that are looking for that, I will go through this and not highlight everything, as we do have some items we need to make sure we cover today. But first and most importantly, I wanted to welcome Bureau Chief Chris Hale. He was introduced at our last round of standing committee meetings, but this is our first time getting to introduce him at our statutory committee meetings. We are very excited to have Chief Hale here. So welcome to the meeting, the group today, Chief Hale. Next, also wanted to mention that unfortunately, both Adam Rodriguez and Julia Vinton are no longer with the Bureau. They have taken other positions outside of the ADHS entity. If you have any share-related questions, your point of contact would be either Josie Johnson or Lahia Castro. So please reach out to either of them as necessary. We also would like to welcome Isabella Foster, who is new and providing administrative support to both the enforcement and CO1 sections. A reminder about our awards ceremonies, which will be in May. So that is at State Trauma Advisory Board in our May meeting, as well as EMCT of the Year Awards at our May meeting of EMS Council. Those are open for nominations. So if you know someone that is a good recipient and you'd like to nominate, please do so. In your Bureau packet, there is the hyperlink to do the award for that. So please make sure you take some time. We really enjoy doing that, and it's been a great outreach within the community. So wanted to make sure we highlighted that. A quick reminder about EMCT certification. We have had a few issues with kind of people working with expired certifications. A reminder, anyone who's certified in the state will get a reminder 90, 60, and 30 days out from expiration. So just kind of reminding your personnel to please stay on top of the recertification applications. I will briefly cover some trauma center changes. There's a new RFP process for our trauma center reviewers. Those physicians that do those reviews should be pretty well aware of that and can reach out to the trauma services, trauma section as necessary. And then the trauma registry update that was covered quite extensively at STAB. Currently, there is an interim option of using REDCap that started 2 days ago, and the Bureau staff is working with stakeholders to kind of aid in that transition. Our strategic plan was updated and approved by the governor's office. There is a link to that in our site. And we also have a new map for training programs. This was a request from our stakeholders. As you can see here, we have a map that breaks down to EMT, AEMT, and paramedic courses. If you can scroll and turn on the AEMT one, you can see that's one where we know we have two programs in the state of Arizona. So we really are very appreciative when stakeholders come and ask us for things like this. We can produce this and bring this back to the committees to see. And then you can toggle on for EMT and paramedic programs as well. So I wanted to make sure we highlighted the work and the follow-up on that action item. Our EMS and trauma dashboards are up to date with 2024 data, and our EMS offload time dashboard is also live. If you were not at the previous two meetings, Vatzel did mention that she has updated that data and that we are looking to, she'll cover a little bit later, but relatively soon should have that within a week real-time data. So very up-to-date data will be available for that. Next, for continued service sections update, EMS for Children. We want to welcome Savannah Sandlin, who is the new EMSC coordinator for the state, and a big thank you to our Education and PACES Committee, who finalized the Children and Youth with Special Healthcare Needs training that is posted to our website as well. Naloxone Leave Behind, I really wanted to take a minute to thank all of our partner agencies and EMS personnel for participating in this program. We have 68 agencies now doing Naloxone Leave Behind in the state. We have just under 5,000 EMCTs trained, so almost a quarter of our certified personnel in the state of Arizona are trained in Naloxone Leave Behind, and over 2,500 kits have actually been scanned. We know that many more kits beyond that have been given out, but that means that when the individual gave out the kit in the community, they have scanned and recorded data as to where that was given out. So we really wanted to say a big thank you. I know we had a little 20-hour pause in the program last week due to some federal changes. We are really committed to continuing this program. We know that in Arizona, we have not seen a reduction in opioid related deaths like other parts of the country, and we do feel like this is a really good opportunity to continue some of the injury prevention. So the Bureau is committed to continue this program, but just wanted to say thank you to everyone who has helped support Naloxone Leave Behind. The share dashboard is live. We have been presenting this at our meetings and just wanted to make sure we'll go over that a little bit more depth later in the agenda with Vatzel. And if you have any other contact information you need regarding certification or enforcement, those links are on here, as well as how to sign up for the Bureau's Gov Delivery communication. All right, we will keep moving on the agenda to our standing committee reports. Dr. Augenstein, are you available for the TEPI report?
Yeah, thank you, Gail. For TEPI, last meeting, Dr. Bradley displayed the offload dashboard. Adam gave share updates, the annual report info viewing the dashboard and agency report info, and shared slides explaining data quality reports that she shares with agencies and also how to analyze for improvement. It was also shared that updated codes for e-scooters, e-bikes are now available with the pick lists. And then Vatzel went through the dashboard for trauma injuries, and that ends my report.
Sorry, I'm mute still. I'm forgetting that I'm the microphone. Let me move over to Dr. Johnson for education report.
So the STRs for the EMT for IV training was approved, and also the training for the children and youth with special healthcare needs for EMTs was also approved. We have two different work groups working on two different projects. One is for training materials for child maltreatment, and that next meeting is on February 12th. And then a separate one for ultrasound guided IV initiation training, and that one is for February 5th. We're also working on maps for the training centers throughout the state, which is what you were referenced.
Correct. All right.
That's it.
Thank you very much. Next, I will move to Dr. Gaither for a PMD update.
My PMD update is strikingly exciting. We reviewed the meetings a minute. We're going to talk about all of the documents that we approved there, including the changes to drug box and adding infusion pumps. And then there was a call to the public talking about the riser.
All right.
That's it.
Thank you. All right. And I do not see Savannah or Dr. Woolrich on the line for PACES update. Thank you. I will briefly give the PACES update. There was a very nice presentation from Morgan Anderson regarding the child fatality report for 2024. There was also a presentation from Amy Devins on the crisis system to help support emergency responders in the state. The Education Committee is going to work with PACES to develop training materials for child maltreatment. We also have asked our State Trauma Advisory Board if there's any interested members, as many trauma centers do participate in that process. PACES also approved the Department of Education Red Book. These are the guidelines for basically schools knowing what basic medical interventions to do and when to access the 911 system. So that was approved by PACES. And I think those are the big updates for that. Thank you very much, Shelley. All right, next we will move to discussion and action items. Can I get a motion to discuss, amend, and approve the meeting minutes from September 18th, 2025? Thank you. All right, thank you. We got a first and a second in the room. The meeting minutes are being displayed right now. Any recommended amendments? Hearing none. Any opposed? Any abstentions? All those in favor say aye.
Aye.
Thank you. Next, we are doing a little bit of cleanup here. We recognize that we need to formally have a vice chair for all of our committees and do need a vice chair for MDC. Dr. Gaither has been willing to step into the role, so we would just need to officially nominate and approve Dr. Gaither unless there's any other nominations from the floor as well. We are open to take those. So I can get a formal nomination? Yes, please. All right, thank you. All right. I hear a second over there. Thank you, Dr. Johnson. All right. And we can, if there's no further nominations from the floor, we can take a vote then. Anyone opposed to Dr. Gaither's vice chair for MDC? Any abstentions? Josh will note you as abstaining. And all those in favor, please say aye.
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 All right. Thank you. Next, we need let me, oop. I lost internet connection for a second. Can you guys hear me still online?
Now we can. We lost you for maybe 30 seconds.
Okay, thank you. Thank you, Frank. So I know everyone loves the idea of having a work group to work on bylaws. We do need to officially review this. I promise this to be a one and done meeting just to review, make sure we don't need to make any updates and bring that back to the next one. Is there anyone that is interested in participating in the bylaws work group? It'll be online. All right, thank you. Okay, thank you, Dr. Johnson and Dr. Gaither. Formal vote, yes. That's my reminder from Shelley to make sure I vote on this since I missed that in EMS Council. Anyone opposed to forming a work group to review the bylaws, please say nay. Any abstentions? All those in favor say aye.
Aye.
All right.
Aye.
Thank you. All right, next, if I can get a motion to discuss, amend, and approve draft table 1 EMCT drug box to reflect removal of optional agent minimum quantities. If I can get a motion, then I will go into an explanation.
So moved, Frank.
Thank you, Dr. Walter. Is there a second? Thank you, Dr. Rice.
Second.
All right. So a little bit of background of this. This was actually a stakeholder request, and once we started looking into it, they mentioned as over the years we've added new medications to table 1. Some of our optional agents had actual minimum quantities associated with them, and others did not. Where that was becoming a problem was if it was an optional agent, but we listed you had to have a minimum quantity. When that ambulance was undergoing an inspection, if they didn't have the minimum quantity, they were out of compliance. And so really what the stakeholder asked was, if it's optional, do we really need to list a minimum quantity versus simply saying, if it's an optional agent, your medical director gets to decide how much that you're going to stock at that. So with that in mind, PMD did go down the list and kind of reviewed each optional agent on table 1. And that is what is being displayed where there is a removal of a minimum quantity for our optional agents. And also had to do a little bit of reconfiguring with some of the formatting just to make sure that that was covered as well. So that is the background and context on that. Any questions about that? We can kind of scroll through here from the top really quickly. So we'll kind of start at the top with albuterol. You could see there for AEMTs and above, it's required. So it's only if it's an EMT only unit was optional. So we've removed the minimum quantity. Similar with aspirin. If it's a AEMT and above, it's required. If it's an EMT only, it is an optional. So the minimum quantity was removed. If we go to next page, you can see for the atropine multi-dose vial, we just moved the multi-dose under the agent column and then put that as an optional next to that. And for calcium gluconate, removed topical gel, removed the 50 gram next to optional. For dextrose, 5% in water, again, removed the 250 ml bag and just put optional. Diazepam rectal gel, again, remove the quantity. Diltiazem, we will get to the green highlight in a second separate vote, remove the milligram next to that. The auto injector, again, just clarifying optional in totality without specifying which. The epinephrine for IM anaphylaxis, again, just listed optional. And then for epinephrine for the multi-dose vial, remove the quantity and moved multi-dose over to the agent itself. Etomidate, remove the minimum quantity of 40 milligrams. Oral glucose, remove the 30 gram next to the minimum quantity. Hydroxycobalamin, remove the quantity and just left it as optional. Ipratropium, for EMT and AEMT, it's optional and the quantity was removed. Ketamine is an optional agent for all levels, and that was the amount was removed. For lactated ringers, for EMT level, it's just listed as optional. For lidocaine topical for IO insertion, listed again as just optional now. And for naloxone, we move the pre-filled atomizer or auto injection to the agent and then remove the number of doses. So page 4. For saline, this is one that we still, we have listed here. We had 1 liter bag, and then we had optional for 250 bag, and then optional for 50 ml bags. So those are just listed as the quantity, but no longer how many you would need to have. So 250 ml or 50 ml are both optional. And then normal saline for EMT level, again, just listing optional, but no quantity of that. For norepi or dopamine, these are both optional. So it's simply listed as a single option next to that. And on Dancitron, took off the quantity. Oxytocin, taking off quantity. Phenylephrine nasal spray, taking off the quantity. Proparacaine ophthalmic or tetracaine, taking off quantity. Rocuronium, dose removed. Sodium bicarb, dose removed. Succinylcholine, quantity removed. And same with thiamine and TXA. So those are kind of the suggested removal of the actual amounts for all those optional agents. Any questions or comments regarding that?
Hey, Gail, this is Dan Spate. That was a really long list. Couldn't keep up with them, and I'm not obviously familiar with, I'm familiar with dosing as we all are, but not always familiar with the variations in how it's supplied. And there are some drugs, so where too low can be an issue, right? Atropine sucks, right? You partially paralyze somebody and then can't get the tube in and that kind of thing. So I just want to make sure that we're not inadvertently providing for doses that are too small in drugs that theoretically could have harm from a dose that's too small. And Frank probably knows all that stuff. He usually does.
So, thank you, Dan. I think there was a discussion about, looking at this at PMD with a pretty kind of robust conversation. Anything that is a required agent does have a minimum quantity. The discussion was really coming up. A good example was etomidate. We had a minimum quantity of 40 milligrams. And what we heard was that really in the clinical setting, we're not ever giving a dose that high. But that was requiring agencies to purchase and carry that minimum quantity. There were many times their guideline called for a much lower dose. And so really
Yeah, I understand that side of it. My question just is, some of the drugs listed could, if stuff is optional, for instance, I don't know if you can get vials, pediatric vials, for instance, that are, you could carry a minimum that's too low for, say, the typical adult or an adult. So I just wondered if anybody's looked at it from that side, because there are drugs you can really hurt people if they give too little. And if you can't give enough, they still may give too little.
I'll come over to you. That's great.
Josh is walking over.
I was just gonna share maybe what we have done locally in Southern Arizona, and I think the tenor of the discussion at PMD at least was that as a medical director, it is my statutory responsibility to review and approve the medications that are in my agency's drug box annually. We do that as a process. We added a minimum supply to our approved drugs list so that for all of my agencies, as their medical director, I approve an individual supply to ensure that the agency does have enough to care for, in my case, an urban setting where they're easy to restock, or I do also have some rural ambulances that have a higher PAR level or minimum supply that allows them to care for multiple patients if they don't necessarily transport. So we discussed it at length and really felt comfortable with that, leaving it up to the medical director to really tailor that to the abilities or response area of the agency, if that helps, Dan.
If I'm the only one, as usual, if I'm the only one that's worried about the concerns, worries overstated, but then I'll let it go. But I have the really long view, probably the longest view of the group. And let me say it nicely, some medical directors are idiots. I'm not concerned about the people who are active and on this committee and functioning actively, and I'm concerned about the checkoff box person who doesn't really even know by their practice. And there are a few drugs, that's why I was asking Frank if he has any concerns, because there are a few drugs that if you don't have enough available, it could be given and it could really hurt the person. Sucks is the classic where you can actually kill somebody, right? If you get the dose too low. So now they can't breathe, but you also can't get the tube in. So, but if nobody else cares, I'll just vote no.
Dan, this is Frank. Would you like my thoughts on that, Gail?
Absolutely.
Okay, so you bring up two good examples, Dan, in terms of atropine, and I haven't looked at, I can quickly look at it, but atropine, the minimum dose in an adult would be 0.5 milligrams. So in other words, a half a milligram. Less than that, you can get the paradoxical bradycardia because it binds to presynaptic M1 receptors, and so that has a negative inhibition. Also, for pediatric dosing, you should never get a child less than 0.1 milligrams of atropine. And of course, as you all know, so I'm telling you all things you already know, but I mean, it's a good point you brought up, Dan. And obviously for succinylcholine too, like you said, you never want somebody partially paralyzed. So 1.5 milligrams per kilogram succinylcholine or 0.1 milligrams per kilogram of rocuronium. As you said, Dan, you never want somebody partially paralyzed, and I'd rather always go on the high side of dosing with either rock or sucks. And I've almost moved exclusively to rock, other than working with our trauma and neurosurgery colleagues. Does that kind of address your concern, Dan? And Josh?
Well, my question then at the crossover is can a medical director check off, sign off on, oh, we'll take one vial of that and it can actually be provided as a vial that they would have their maximum dose would be too low for an adult patient that they're caring for, but they're not really thinking about that. They're just signing off on it. So this, to me, this is the last safety check, and substance to me is the classic. Well, aspirin can really hurt them too, but substance is the classic. You can take a breathing patient and make them poorly breathing, not get the tube in, and they die. That is not inconsequential. And what I don't know is whether you can buy a vial of sucks that's too little for an adult that you might take care of. That's why I was just bringing up those two.
Yeah, and I think the conversation that we had was that the dosing that you're providing the patient is listed in the protocol itself. And so we're not changing the protocols. The protocol still has the minimum adult dose for atropine is 1 milligram. So you would always have to carry at least 1 milligram, you know, to be able to follow the protocol. So I think our discussion was the protocol dictates the dose, and that's sort of evidence-based protocols. And then the medical director can carry whatever multiple quantities of that dose they think would be necessary based on the operational needs of that particular agency. So it lets you go down to a single dose in the drug box.
No,
of something versus
hey, Amber,
full
I
dose.
understand all of this. I don't make we don't even know how many medical directors we have in the station. It's just a really long view of we've had some unintended consequences, and then you find out, holy cow, who would sign off on that? So if everybody's confident that if they stop it, there will never be a time where they chose to just get one when they needed 3 or whatever, then like I say, I'll shut up.
So Dan, I think atropine specifically, there's no change to the required. The only change is for agencies that chose to carry a multi-dose vial. So that's really the only.
Good, that takes care of that.
Yeah, so atropine is not an issue. I don't see Sux is available in anything less than 200 milligrams on a quick Google search. So I don't see a lower quantity available for purchase. I've also not seen rocuronium carried in anything less than 50 milligrams either. I see some head shakes in the room. So I think the 3, I think atropine is a non-issue in just regards to there's the required doses not being changed, but I don't see smaller quantities available. I see
That's great.
his hands up.
That's great. No, Gail, I just didn't know. Like I said, I just didn't know if you could end up with a small vial, you have one and then you're in trouble. So that's great. Good work.
Gail, while you were doing your Google search, I went on Daily Med from National Library of Medicine, National Institute of Health, and I just typed in anectine just to get a trade name to narrow it because they're more generic quantities or generic formulations of succinylcholine. And I found exactly the same thing you did. There were 3 entries for anectine, and they're all 200 milligrams per 10 mils. So 20 milligrams per mil. And I can quickly look in Daily Med and I can share those links too if you want them. And I can quickly look in Daily Med for rocuronium too. And thank you, Amber, for stating that the state protocols, the minimum dose for an adult is 1 milligram. And again, when I said a half a milligram, that's an absolute minimum. So I'm glad we as MDC decided 1 milligram. Do you want me to look at rock quickly or not, Gail? What's your pleasure?
It is Dan. I'm happy to release conversation for us to vote and so forth. And if something comes up, we can always come back to it.
Okay. So do you feel comfortable moving on a vote then?
No, I'm happy. Yeah.
Okay. All right. Thank
That
you.
info is really helpful. Thanks.
Anyone opposed to removal of the optional agent minimum quantities as discussed, please say nay. Any abstentions? All those in favor say aye.
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 All right. Next up is, the next agenda item is to discuss, amend, and approve draft table 1 to reflect addition of infusion pump requirements for Crotalid immune nicardipine nitroglycerin IV, saline 3% thrombolytics and vasopressin agents. So it's all quite a bit of mouthful, but if I can get a motion, please.
So moved.
All right, I think Dr. Walter first and second Dr. Johnson. Thank you. This was just something that we realized we had on some areas a little bit of inconsistency. So as we scroll now again to that draft table 1, you will see that we have added IP, just recognizing that as the top of the key demonstrates, an agent shall be administered with an infusion pump. So for patient safety. So on page 2, you can see next to Crotalid, IP has been added. Yes, Dr. Walter.
I've got a concern about using the abbreviation IP. I know the key says infusion pump, but in pharmacology and pharmacy and medical research, it usually means intraperitoneal. So I don't know if there's an alternate abbreviation. It's a standard abbreviation IP for intraperitoneal.
It hasn't been changed, so it's been IP. I don't think, correct, Shelley? The
Yeah,
key?
maybe I'm solving a problem that's not there, and but just a thought.
Okay.
If it's not broken, I don't want to fix it. And I know our medics would never give anything intraperitoneal, so maybe it's maybe it's too much detail.
Yeah, I think it has been IP on our drug tables. Brian Smith is shaking his head. He is our historian for many, many years, so that is not new. I think what was missing was having it next to some of our newer medications that are on the list. So let's see, back to the list of medications. So we have added that to Crotalid on page 2, on page 3, nicardipine, nitroglycerin IV, on page 4, saline 3% hypertonic, and then thrombolytics. So I think that was a good pickup to make sure from a safety perspective that we do have infusion pumps listed there. All right, any further discussion on that? All right, hearing none. Any opposed to the addition of IP next to those medication options? Please say nay. Any abstentions? All those in favor say aye.
Aye.
Also, I.
Aye. Thank you. All right, next, if I can get a motion to discuss, amend, and approve the addition of metoprolol to draft table 1, EMCT drug box.
So moved.
Thank you, Dr. Walter. Thank you, Dr. Rice. I don't know if you wanted to.
Yeah. Within the last couple of weeks, we received notification that the manufacturer that makes the diltiazem formulation, that's the powder that you reconstitute, has discontinued that product, and it will no longer be available to us. So the pre-mixed version of it is still an option. However, it requires refrigeration down to the level at which most of our agencies don't carry the super coolers anymore. Talking to the pharmacist, if you carried that medication in your regular refrigerator, you'd have to throw it out every 30 days. Because of that, we will lose the option in many of our agencies, really just operationally, to carry diltiazem. So the ask for this committee was to simply add the checkbox for metoprolol, so that agencies could have the option of either, as an optional drug again, diltiazem or metoprolol for the indications of mainly the tachycardia. So that's it, if anyone has questions. But
Thank you. I see Brian, I'm going to come over to you. All right.
So metoprolol is already on the list. Right now it's on there for critical care. So all you need to do is, if you want it for paramedics to do that in replacement, because we've been notified of that same issue. All you got to do is add an A to the metoprolol that's already on there. You don't need a separate line for that.
Yeah.
Okay, because it was on the list as diltiazem or metoprolol on the list.
Yeah.
And that's a formatting issue on our, they're both optional, so.
Yeah, they're both, and
just to add the checkbox to the paramedic.
it just made it look like, the way it was written, it just made it look like this is trying to use metoprolol as an indication for the same thing, they'll thiazide where it's already on there. They can use it for whatever they want. The question is, do you want paramedics to be able to use it and not just critical care paramedics, right? No, so that's just the way it got written on the list. So.
Yeah. Yeah, but that was my error. I did not catch it either. So thank you for bringing that up. So that is where we have on page 2 in green, diltiazem or metoprolol. As pointed out, we could then go to page 3, and where it's metoprolol optional, it would be added as an A under paramedic column.
Yeah, sorry, Shelley, I didn't notice that the other day. I saw the A in the column and that.
Yeah. Any further discussion on that?
This is Frank. I support that. And I also dropped in the chat the new guidelines for resuscitation, and specifically relating to using beta blocker in volatile inhalations. And that's why we have propranolol as one of the toximetic drugs. And metoprolol could also replace propranolol. Metoprolol would be a safer beta blocker because it's cardioselective, beta 1 selective, whereas propranolol is not cardioselective. So more risk in folks with asthma or COPD, other bronchospastic diseases. So again, that's not the issue now, but I think this, this will help. I think this will help moving forward for another issue, maybe removing propranolol eventually and using metoprolol in that setting.
Thank you. We can definitely, since that's not an action item today, we can put that on the PMD agenda. Normally, we always do drug table changes through PMD before MDC, but because of the ability to get the medication, we wanted to put this on a discussion now. But that is a great discussion to add that for PMD, Dr. Walter. Thank you.
Yep. No, and that's great. PMD is just perfect as usual. Yeah, I didn't want to do anything out of order or sequence or anything like that, but just to bring it up since you asked for further discussion.
Yes, no, that is great. We have that noted for that next meeting in March. All right. Any further discussion regarding the addition of metoprolol as an optional agent under the paramedic column? All right. Hearing none. Any opposed, please say nay. Any abstentions? All those in favor say aye.
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 I'm sorry, was that, I heard aye, so I thought someone was maybe speaking up to say something differently in the background. Oh, we are good then. All right. Next action item, discuss, amend, and approve the edit to remove the 0.5% from the phenylephrine nasal spray line from table 1. Brian, I think this was a request from you. Pardon? Yes, please. Thank you, Dr. Rice. Can I get a second?
Second.
Thank you.
So I was recently notified by one of our agencies in an outlying area that doesn't reach Flight FMC that a lot of their local medical suppliers that have pharmacies are no longer stocking 0.5% phenylephrine nasal spray. It's all 1%. So my request, so they had to go to their local Walmart pharmacy in order to resupply with their expired drugs. So my request is just to remove the percent on there for phenylephrine nasal spray. And so this is another one of those things. I recognize I'm bypassing PMD, but this is kind of something I think easy to do and needs to get addressed. And there may be other people in the same place if they're using the medication. So my request is just to remove the percentage of it and clarify that it's phenylephrine nasal spray, though.
Any further discussion? All right, hearing none. Is there anyone opposed to the removal of the 0.5% next to the phenylephrine nasal spray? Please say nay. Any abstentions? All those in favor say aye.
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 Next action item, can I get a motion to discuss, amend, and approve the edit to add metoprolol to the TTCG for tachycardia with a pulse, adult and pediatric?
So moved.
Thank you. Is that the first, Josh, was that you? Second, okay. All right, we've got you both down. Thank you. Yes. All right. Thank you for drafting this. I believe was Dr. Rice. So you can see here as displayed, there is the addition for paramedic only for stable SVT or irregular narrow complex SVT or tachycardia. The metoprolol 5 milligrams slow IV over 2 minutes may repeat every 5 minutes for 3 doses total. Hold a systolic blood pressure less than 100. So that is the proposed verbiage to be added to the TTCG. Pretty clean and simple. Any further discussion? All right, hearing none. Anyone opposed to the additional as displayed? Any abstentions? All those in favor say aye.
Aye. Aye.
Aye.
Thank you. All right, I think those are the last of our voting items. Next, we're going to move, oh, yes.
When do these changes go into effect / will be published?
The TTTG is pretty much as soon as Shelley can do the change and get uploaded to web posting. The drug tables go to the director's office for approval, and once approved, then we post those.
Okay.
Yeah, it's oh no. Nope, they're very very good at getting that done rapidly once it's gone through this. Yeah.
But the bottom line, if I message to them that they should look for these changes effective in the next 2 or 3 weeks.
I think very reasonable, yes. Yeah. Because these are pretty kind of substantial changes, we will message it out by a good delivery. Yeah. All right. Next, I'm going to come over to Chief Hale for just a brief discussion on the recertification process for EMCTs.
Yes, we're just trying to improve our verification system. And we're just asking EMTs to list out the courses that they've taken during their recertification time. And any additional information we will discuss with them at a future date. But we're just asking them to list it out to help our process. And that's all for now.
Okay. Thank you. I need to come take a seat next to you, Brian. Coming. 1 second, just so they can hear online. Oh, here he is.
So if they have national registry, the stuff that they've uploaded to the national registry, will that automatically come to the state when they renew it? Or is this only for people who are state only licensed?
If they are national registry, then let us know that's part of the design.
Yeah, so if you couldn't hear online, if you have national registry, just submitting your national registry is sufficient. Thank you. We will have, there was quite a bit of discussion, EMS Council, so we will have some follow-up on this at the next round of meetings. Thank you. Next, Vatsal, are you on for a discussion on the offload dashboard?
Yes.
Excellent. I will turn it over to you then.
Okay. So for the offload time and response time data, we are planning to have almost a real time. So when I say almost real time, that means maybe a week or few days lag in creating a dashboard for you guys, which we had some technical difficulties with the Snowflake environment and receiving data from the image trend. That part is now resolved. So we do have all the current data, and we will start working on developing that dashboard for you guys very soon.
All right, thank you, Vatsal.
Mhm.
And then share dashboard update as well.
Sure.
So
Can
now
I?
you can share your screen, yes.
Okay, all right.
So I'm going to embarrass Vatsal again, as I've embarrassed her in the last 2 rounds of committee meetings. But, oftentimes when people see data, their eyes kind of glaze over and they really just look at kind of data discussions, but not the actual effect of that data. And Vatsal really helped lead an initiative statewide looking at off-road vehicles and injuries related to that. As a result of that, Game and Fish produced quite a bit of education, and legislation was passed to address off-road vehicle safety. And Vatsal was actually awarded and given an award this past Saturday by Game and Fish for her efforts to address safety-related incidents with off-road vehicles. So I really wanted to say, a lot of times with data, we kind of just go, oh, it's data, what do you do with this? But really the data that EMS personnel take the time to record, your agency submit to AZ peers, our trauma centers put in, that data can be used to actually improve outcomes across the state. So I wanted to make sure we recognize Vatsal for her work.
Thank you once again, Dr. Bradley. Okay, so cardiac arrest annual report is available on our website. I won't talk in detail about the cardiac arrest, but I just want to give you a little bit of information on the registry. And when we received the registry, I think a year or more than a year from University of Arizona, the whole transition happened at the state. It is now, we are at a stage that the registry is real-time registry within our Snowflake data lake house. And what does that mean is that the population gets selected, the cardiac arrest population gets selected from the AZPS data. And so we have that EMS pre-hospital cardiac arrest populations. Then the hospital submits data to us on the cardiac arrest through the REDCap. That REDCap portion of the data then gets uploaded back into Snowflake. So within the Snowflake data lake house, we have now a pre-hospital cardiac arrest. Yes, Frank.
Oh, I'm sorry. I don't need to interrupt. I just wanted to get in the queue when you're done, Vatsal. I just had a question for you.
Sure. So we have now these EMS pre-hospital cardiac arrest populations available real time. The hospitals, as soon as the hospital submits data into the REDCap, that data gets into the Snowflake. And now both the side of the database talk with each other within the Snowflake and gets linked. Every month they get linked by machine learning process. And because of that, entire thing is now running so much real time that we are able to now provide hospital feedback on a regular interval regarding any missing cardiac arrest cases. So giving them the list that, okay, hey, the EMS agencies now submitted this as a cardiac arrest case, but we have not received an outcome from you guys. And so the hospitals are getting that feedback every quarters, and they are getting enough time to enter the data for this outcome. So maximizing, basically, it is very important for us to get the outcome for cardiac arrest cases. And I'm hoping that we will see more and more data linked at the hospital level because we are receiving more and more outcome data. So with that entire process is now running smoothly, we then developed our cardiac arrest annual report. And as you see, it is available on our website. We have several dashboards available. The first dashboard over here is cardiac arrest annual report. And it talks about the total population of cardiac arrest. This 12,000 is like kind of a total number of cases submitted in AZPS by all the EMS agencies as cardiac arrest. Now, not all gets qualified as a shared population. We have a definition for the shared registry. So based on that definition, the cases gets excluded, and that this bucket is like, this is the shared population as entered by the EMS agencies. Again, those cases, cardiac arrest cases, we have a very high, very low survival rate. We know that. And so there are many like EMS termination of suscitation happens on field. and then the remaining gets transported to the hospital. Now, those who get transported to cardiac receiving or referral centers, we get their data back from the hospital. Those who are not, and there is no way for us, like, 1,100 some patients went to non-receiving center, and only way to receive outcome from them is that if in case the outcome is available in EPCR, like if the EMS agency knew what was the outcome at the hospital and they entered it, then that's the only way we will know, because we don't get data from them. So we even capture that information. If it is available in EPCR, then we would like to know that. And then the remaining cases we went to cardiac arrest center, how many we were able to successfully link them to EMS records. So right now our linkage rate is around 59%. Hopefully, as more and more feedback we give it to the hospital on a regular interval regarding missing cases, I'm hoping that we will get more cases, we will have more linkage and more outcome data than available to us. So then finally we have, that is a population where we have the outcome available to be included in the analysis. So then we talk about the summary, again, what was the field outcome, what was the patient's final outcome, if the Houston population, and what is this, again, the Houston population. If I select over here yes, then it will give me the outcome on the Houston population. It also talks about demographics, some age, gender, county level information about the cardiac arrest cases. And then we have field characteristics like, okay, what was the median response time, the percent of witness cases, bystander rate, ROS, the percent of ROS cases, of AED, and that information. And then the final page is about the final outcome. So those patients where we, as I told you, showed on the first page, all our selection criteria, that patients where we knew the outcome, then that's our outcome. So our survival rate in the final bucket is 5.6% survival rate. And what we have over here, what you see all these graphs around the patient final outcome, is those are the factors they affect the outcome of the patient. So CPR, witness cases, shockable rhythm. And here I can choose basically, okay, bystander CPR, yes, and then it will tell me the survival increased from 5.6 to 6.5%. If I do witness, if the patient is a witnessed cardiac arrest, look at the survival increase to 9%. Response time over here, we actually divided the response time into different categories based on your guys' input. And what we can see is that as 0 to 4 minutes has a highest survival, and then as the response time increases, the survival decreases. So it goes to, from 6% to 3% survival rate. So half the survival rate happens. So that kind of information is available. We have a CPC scale information based on the hospital, how many patients and what was their CPC scale, those patients who survived. Based on these, we have also created agency level reports and gave agency their agency specific cardiac arrest cases report. So it looks very similar to what you saw over here as in the annual report, but it is only limited to the agency. The agency can then come on our website and look at the statewide report to compare or have some kind of a benchmark to see where they stand. Now, one more thing we have done in agency level report is to give them some feedback on the data quality. There are few data elements we have included. For example, if you have said that there was a ROSC or patient achieved ROSC, but not documented a ROSC date and time. And another one will be like, there is how many the patients received shockable rhythm was documented, but then we do not have defibrillation date and time. So things like that is included in that report. There is more scope in that on that page. If you guys have any feedback to include more data quality variables into that, please feel free to let me know, and I will make it that happen. So that's for the cardiac arrest report.
Thank you, Vatsal.
And now you had a question, Walter.
Yes, Dr. Walter.
Yeah, congratulations, Vatsal, on your award. And just a question, as I see that the fifth highest etiology of out-of-hospital cardiac arrest was drug overdose, in 2024. Just a few questions. Do we have any further detail? My suspicion would be that they were due to fentanyls. Do we know have any more specificity on that? So that's question number one. And then question number two, since we have this data over time, or these data over time, has that percentage due to drug overdose been going up or down, and has that been compared to the naloxone leave behind? Obviously, the percent of drug overdose deaths is going to be multifactorial, but that's one concrete thing we've been doing as a state.
Yes, so we can definitely look into that. This report does not show that information, and that's a limitation. It's a statewide annual report, but that we can definitely dig into it to figure out what is going on. And I think I would like to ask Anne to answer this question, and if we can look into the EPCR to see like what kind of drugs we do collect that information, right?
Correct. We do collect the information, or we do collect information on the drugs given to the patient. And if it's completed correctly, we also collect information on whether or not that agency gave the drug or was given prior to their arrival.
But I don't know, unfortunately, I don't know that we would have access to the drug involved in the overdose death. So to Dr. Walter's question, is this an acetaminophen overdose that causes death? Or is this an opioid or fentanyl overdose? That's something that I don't believe is at any pick field for EMS that I'm aware of currently.
Yeah, that's correct too. So unless, there are ICD-10 codes that can be picked as the impression or whatever else saying that, but I don't think generally people in the field are going to know for sure what kind of overdose that is. So usually it's just, it might say opiate overdose, but they're not going to know really if it's, a prescription medication or another kind of drug or whatever.
Sure, and just the general term opioid would be fine too. Is the data linked to, say, hospital ICD-10 coding for opioid overdose, or coroner or medical examiner data?
It is not linked to medical examiner data, but it is linked to hospital discharge, because that is what Watts was referring to, of kind of the hospitals inputting the data. That's what we're really trying to improve, that linkage. Right now we're at 59%, which is still very good compared to most states.
Yeah.
Really what we're hoping to is to get a higher linkage. But Watts, I don't know if you had anything else to add to that.
I don't, but we also have this opioid dashboard available. I'm not sure what kind of information, I know, but what detailed information is what we are looking for, and it's available on the dashboard or not, but we do have an opioid dashboard on our state website.
Thank you.
And which involves not only the EMS data, but they involve the hospital level data also in that.
Any other questions or comments? One of the things maybe we can just highlight the response time and survival rates. I think this is something we did highlight at one of the earlier meetings today. I did want to mention, if you can click on that tab, Vatsal. One of our stakeholders from STAB had actually requested that we break down our response time intervals into smaller metrics to look and see at what inflection point we saw a significant drop in survival. And so we have, when you look at the dashboard, there's 0 to 4 minutes, 5 to 8, 9 to 12. And you definitely see that once you cross over to that 9 to 12, you see a significant reduction in survival rates. We do know as well, obviously in more rural areas, bigger geographic areas to respond to, that response times are simply going to be longer in those areas. And so part of what we are looking to do is to try to get funding to address some of those gaps. So things like when someone calls 911, are they getting CPR instructions given to them? Looking at increasing bystander CPR rates, AED used by law enforcement. All of these different interventions can improve survival from out-of-hospital cardiac arrest, so that we can shorten that time to get hands on the chest and also shorten the time to defibrillation. So really now having this data, having this be much more up to date, those are some of the kind of prevention works that we really are looking to move forward on. And this is what Vatsal is demonstrating here. If you look at the bottom left corner, which is response time, and then the pie graph in the center, you can look at survival rates. So if you look at 5 to 8 minutes, the survival rate, and then if you click on 9 to 12 minutes next to that, you'll see that survival rate drops down. And if you click on 13 to 15, it goes down even smaller. So you see that little gray bar, which is your survival, that gray slice of pie getting smaller and smaller. The other part is bystander, CPR being done. So if we click yes on bystander CPR, survival is much higher than if you click on no for no bystander CPR. So if the first person doing CPR is EMS arriving on scene, we know right away that that person's chance of survival is significantly lower. So big thank you to everyone for all of your patience. I know it took a little bit of time for us to get to this point of having the share dashboard. This is new for us. Before we had a share annual report. Now we have the dashboard, which is more something that you can click on, adjust variables, look and see how those different variables affect outcomes and survival. And so really excited to see this work moving forward. So thank you to everyone's patience in regards to that. All right, hearing no other discussion regarding share, I just wanted to briefly cover for the medical directors, there was a national webinar co-hosted by NAEMSP and the DEA a few months ago, really kind of addressing a possibility of EMS agency DEA registrations. I think many of us were quite excited that we thought there was going to be some late breaking news coming out. There was not, is the short version of that. There are some states that do have the ability to essentially allow for an EMS agency to get a DEA registration. I spoke at length to the DEA liaison for Arizona, as well as to the head of the Board of Pharmacy. Right now in Arizona, no one has the authority to give EMS agency kind of a recognition to go get a DEA registration. So that is kind of the short version of that. We wanted to at least acknowledge that for our statutory committees. We did get quite a few questions after that webinar, and just to kind of answer, unfortunately right now it's business as usual in Arizona. There are no changes that we can make because we don't have any regulatory authority to do so. So just wanted to make sure we at least mentioned that at this committee meeting. Questions or comments from anyone? All right, hearing none. Agenda items to be considered for the next meeting. If you have anything you would like added to the agenda, please make sure you send that to Shelley Bissell or myself. We have captured the couple items for PMD, so thank you for bringing those up. Call to the public. All right, upcoming events are listed on the agenda. Our next meeting will be May 21st. For those of you that don't normally come to EMS Council or STAB, we will be giving out our annual awards, the Trauma Awards during STAB and EMCT of the Year Awards during EMS Council. That is really one of the nicer events that we have. So I just wanted to put that on your calendar if you did not normally come to that meeting.
I also had a late ad for events. There's a pediatric stimulation training course, April 30th in Guilford.
Okay. All right, thank you, Shelley. If I can get a motion to adjourn. All right, I see a couple motions in the room. Thank you very much, everyone. Have a good rest of your day.
Thank you all.